Tonight's webinar is part of the EI Café webinar series, a bi-monthly educational event aiming to bring together experts in working equid care from all over the world. I'm Dr. Angie Barnum. I'm Education Director for the organization. The Equitarian Initiative, or EI, is an international nonprofit with a mission to sustainably improve the health and welfare of working horses, donkeys, and mules and their families across the world. Our EI Café webinar series, one of many educational offerings, is designed to create a cafe-style space to share knowledge, challenges, and successes in the field. One of these challenges we've noticed, especially among our student participants with equitarian field programs, and one challenge we've heard from you all, is that respiratory disease presented in the field can be a diagnostic and management challenge. Dr. Phoebe Smith, specialist in equine internal medicine at Riviera Equine Internal Medicine and Consulting out of Santa Ynez, California, has graciously agreed to present a stepwise approach to the equid with respiratory disease tonight. She comes at this topic not only as a large animal internist, but as a past volunteer on equitarian programs in Latin America. So she has experience with the working equid patient among many other types of equine patients. So it's my pleasure to introduce her tonight. Dr. Smith completed her residency training at the University of California, Davis, after graduating magna cum laude from Auburn University's College of Veterinary Medicine. She has been in private practice and most recently assistant professor of equine internal medicine at The Ohio State University. She is now employed by Riviera Equine Internal Medicine and Consulting, and as well, she engages in professional service with the American Association of Equine Practitioners, the American College of Veterinary Internal Medicine, and the Equitarian Initiative. She also serves on the board of various community and animal organizations in her local community. We are grateful to have her service and expertise, and I think you will find her presentation to be full of tips that you can use to help students you may be working with in the future, whether that be on equitarian programs or elsewhere. You may also pick up some reminders or tips for yourself, of course. So tonight's event is a lecture style with time for Q&A following. As mentioned, it will be most applicable to equine veterinary professionals and students. The following are expectations that we have of you as participants. We do ask that you mute your microphone as you are listening. If possible, please do turn your camera on. We welcome that. If you have any questions during the lecture or after, please post those in the chat. Phoebe is happy to answer those in real time as she's speaking, and we will just direct those to her as your hosts, myself and Andy Henderson. If they are not pertinent to the topic, please post them at the end of the talk for the Q&A time. Tonight's webinar does not offer CE. It will, however, be recorded and shared to all registrants later. And then there will be a survey at the end that we'll put in the chat, and we would appreciate your feedback on that. So Dr. Smith, we are grateful for you, and the virtual floor is now yours.
Hi, everyone. Thanks for joining in whatever time zone you're in. I just sort of dashed in from what is still really hot, baking Southern California weather. So it's probably good that I'm not in person in front of you because the collar is clean and that's about it. I want this to actually go. There we go. So this presentation is part lecture, part memoir almost. In January of this year, I had the opportunity to what I thought was sort of check a bucket list box. I've been in practice long enough to be in a position to be able to really give back. And I thought that Equitarian Initiative sounded like a great way for me to begin that sort of part of my career. I also wanted to celebrate my fantastic technician, Elise, for working with me, putting up with me, being my right hand for 10 years. And so we did this signed up and were selected to go to Costa Rica, the Osa Peninsula specifically. We had a little bit of an idea of what we were getting into, but it's one of those things that nothing can prepare you. Sounds like many of you have volunteered for EI, so and perhaps more often, than the one time that I have. But I wanted to give you that background. That's sort of where this came from. This is the view is taken from a plane, and that's what it looks like. It's a beautiful, beautiful country. The working horses, certainly in the Osa Peninsula, have a very different working life than the horses here in Southern California. We say the horse is in full work here, right? The jumper on one side of the screen is in full work to be able to perform like that. So are the horses on the other side of the screen. They are in full work, these horses. In this area, in the Osa Peninsula, the horses worked pulling carts in the palm fields, often sort of ill-fitting harnesses. They worked on ranches with cowboys on cattle ranches, and they worked in tourism. So sometimes, being ridden by tourists. And they were all also in full work. And what most of you probably already know is the real limitations to care in the working equid are twofold. And these are my words. I'm no expert. There are some experts among us, and certainly I'd love to hear from them when the opportunity arises. But it really became pretty clear to me: resources and education. That's what it came down to as far as what limited the care, because the people, horses are part of their culture. That became very clear, much like they are in my part of the world. And they were interested. They just didn't have either the resources or the knowledge or combination of both to provide a different level of care. So we saw a lot of medical maladies. Sort of respiratory disease was not a primary one, and I'm going to get to that, but just wanted to share with you in case Costa Rica is not a place that you've been able to work with these horses. We saw a lot of ectoparasites. The image with the ticks in the ears shows you there are 1 million baby ones. You can see the big ones well, but if you zoom in, you'll see all the baby ticks. And then that's not glitter eyeshadow lining the eyelid, that's ticks. So that was pretty common and sort of didn't excite anybody except the newbies like me. Whoa, that's a lot of ticks. Certainly malnutrition was a primary problem that we saw. And that was interesting to me. There was more green everywhere, more green grass than certainly we have in Southern California. And it clearly is not super nutrient dense because many of the horses were in what I would consider poor body condition, though I did have to adjust sort of my expectations of what is normal. And then we saw some oddball cases like the poor gray Eeyore looking horse, which I'll get to. So this slide a little bit more closely represents the sorts of horses I see. Granted, I practice in a pretty charmed area. I recognize that. But the point I wanted to make here is typically when I'm seeing a respiratory case in my practice, it usually presents for respiratory disease. So I know what I'm going into. The complaint might be cough or nasal discharge, occasionally increased effort or noise, sometimes a little bit more nebulous like weight loss or fever, poor performance. But in general, well, I'm never quite as tidy as the veterinarian there with his press shirt. I'm probably never quite that tidy unless I'm giving a talk. But there's a proper halter and a lead rope on the horse. There's an able-bodied assistant whose hair is also very tidy. So I don't know if this is a realistic photo, but that's in sharp contrast to the experience, certainly that we had in Costa Rica and that I imagine that's everywhere in this setting. And while I wasn't expecting, I wasn't expecting it to be like my own practice, it was still quite an adjustment to work through the diagnostic process given these factors. I would say nearly always in cases that we saw where respiratory disease was detected, it was actually not a presenting complaint. So in other words, the owner was unaware that there was a respiratory component, something going on with this horse. So that's an issue, right? You have to be respectful and a little bit gentle about saying like, hey, did you realize your horse is huffing and puffing? There definitely were some unusual remedies. Many of them involved, diesel fuel or drained oil, used oil from vehicles, from motors. A language barrier. I like to think I speak pretty decent barnyard Spanish, but there's a dialect and there are phrases and sayings that really actually made it pretty difficult to communicate. I wouldn't have survived without the veterinary students who were there with us for a number of reasons, but starting with their translation skills. And then pretty quickly, it was clear we were not in Kansas anymore. The diseases and conditions in the region were not the things that I see. I wasn't looking at, influenza, and I wasn't looking at just the more typical things that we might see in practice. I had to share this one. It's a total aside, but when I said I was unfamiliar with the diseases, vampire bat bites were so common there that they were like, yeah, whatever. And so truly on this first day, I was a little bit reeling going, where am I? And like, quit focusing on the vampire bat bite and actually look at what's the rest of the horse. And so, yeah, it's wild, but they're like, yeah, it's fine. I put some diesel on it. It's fine. It was in that sort of mayhem. Some of the mayhem was in my own mind. That I realized, and I'm there to teach students, right? And teach the owners. Okay, I need to just fall back on the systematic approach that I use to work up a respiratory case and not get excited about these crazy things and not get sort of waylaid by the aspects that were unfamiliar to me, but rely on the process. And so this is the same process that I use in the Olympic athletes that I work with, the backyard ponies that I work with, and that we instituted working with the working horses in the Osa Peninsula. And it is not news to anybody that you start with a history. And that process was a little bit different, of course. I like a period of observation that occurs during the history taking and sometimes in addition to the history taking, where I'm actually observing just various things about the horse that I'll mention. And then, of course, a physical exam. And those things combined, this is certainly a developmental process. So the history and observation and physical exam then lead me to what diagnostics do I want to perform. And then a bit of a plan. I was aware in this setting that the plan was all fine and well, but we really in this setting have limited or sometimes no follow-up. I wasn't sure how compliance would be, right? Would these horse owners comply with what we recommended? And then truly the availability of medications is, it's really limited. We were lucky enough to have on some of the days a resident veterinarian from the area with us, and that was also fantastic. I really appreciated that in terms of him helping me understand. We worked together on cases. Really loved that. So this is sort of how I would take a history. And those of you who've been in practice a while, like I have, not naming years yet, you have sort of your spiel. Let's say you have the questions that you ask. I'm sure Elise, my tech, could sound exactly like me and rattle off all the questions, because I do. And it's not because it's boring or repetitive, but because I don't want to miss anything, that I do sort of the same standardized set of questions every time. I don't want to omit something. So how long have the clinical signs been present? This was tricky again, because many times the owners were unaware that there were clinical signs that brought the respiratory system sort of into focus. Are there any other problems going on with the horse or comorbid diseases? Are others on the property affected? That was surprisingly difficult to get an answer to as well. Is there a history of travel? Normally, I like the word that rattle off any history of travel or showing or new horses. Well, you can't say showing. That's ridiculous, right? And they'd all traveled a great distance to get there. So I hope you're starting to get the idea that even the taking of the history, while the important first step, it's different working with this group of horses versus my practice anyway. And then these are some of the other questions that I always ask about if the clinical signs are present at rest, when eating, I would usually say at exercise, and are they working as expected? The sorts of clinical signs that caught our attention and led us to investigate the respiratory system were tachypnea, weight loss, and weight loss had to be reported, right? Because many of the horses were very thin. And so really inquiring with the owner about, has this horse lost weight in the last few months? Yes or no? Of course, cough, nasal discharge. And the thing that I learned is the owners would say the horse is not working. And I thought, oh, that's nice. He's on a vacation. Or you're just substituting, letting someone else work right now, and this horse gets some time off. No, not working meant he's not working well. So the observation piece, once I'm sort of satisfied with, I've gotten the history that I want, then I look for a couple of extra things. And all the while I've been watching the horse for some of this. I do like to see a horse lower their head, ideally. And normally that's with, a little bit of food on the ground or something, and that will satisfy. I do like to see a horse swallow as well, sort of watch and hear them swallow, see if any abnormalities. The reason for the lowered head is occasionally you'll hear a respiratory noise, a stridor that was not audible with the head elevated. And then occasionally you'll see a nasal discharge that only occurs with the head down. I always look for flared nostrils. However, in this setting and in many of the areas that EI services, the ambient temperature and humidity are quite high. And so the horses, many of them were a bit tachypnic with flared nostrils. And again, many of them had traveled on foot a great distance to see us. And so we really had to take all of that into account. And then, of course, observing effort. And I like to look at resting rate when the horse is sort of left alone, not necessarily when somebody is holding them up close and I'm putting my stethoscope on them, because that does sometimes change the resting rate in a nervous horse. I'm going to move your cute little faces that I can see over so I can see there. Nope, can't move you. Can you see where I moved? There, that's better. All right, so physical exam would be no different from your physical exam. The one recommendation I have for this is to be systematic about this. I'm a big proponent of doing things the same way every time, the basic level exam, so that you don't omit something, because invariably somebody asks you a question or points something out and you take the stethoscope out of your ears, right? They always talk when you have the stethoscope in. And you can kind of forget to look at something. And we've all done it. I know I've done that, but I try really hard to be very systematic and almost checklist-like in my approach to the physical exam. I like to start at the front, put my hands in front of the nostrils to feel for the airflow, stick my nose close to their nose and check for an odor, palpate submandibular lymph nodes, and of course pharyngeal palpation, and check the temperature in the working horses. In this environment anyway, determining fever versus hyperthermia was an interesting question. And that is more easily done when you have diagnostics at your fingertips, but we'll talk about a little bit more about that. I do encourage, even for a primary respiratory case, a very careful cardiac auscultation. We actually saw 2 horses with an arrhythmia with atrial fibrillation, and they did have a complaint of not working as well. And so turns out perhaps not respiratory in origin. Usually with atrial fibrillation, horses can still work, but I think in these cases, there were some confounding factors. So careful cardiac auscultation, of course, the lungs, the silver lining to these super thin horses is you can actually hear pretty well. A lot of our slightly obese horse population, it's just not a very sensitive tool, pulmonary auscultation. I do it and I do detect little things, but I know it's not very sensitive in a well-fleshed horse. And then I really like a rebreathing exam. Not every horse will tolerate it, many will. And we did some. We found, a sack or a bag. I can't remember quite what we'd used, but we just sort of look around and find something. I do like a rebreathing exam. The bag over the nose. I don't like a gigantic bag because that takes way too long. The idea is the horse is exhaling CO2 and then having to rebreathe it, right? And so when the bag is removed, they're a bit oxygen deprived and they're going to take several deep breaths. And so it allows for a much more sensitive auscultation. And I'm also looking at, does the horse cough when you remove the bag? Does it take them, 12 breaths to recover or 3? Because somewhere in the 3 to 5 breaths is pretty normal. That they take 3 to 5 big breaths and then they're back to normal. So I do it on both sides of the horse, and I use a small to medium bag. Can you hold off the nostrils? Absolutely. And sometimes that works better for me in the young animals. But I think that I get a better, they're less sort of freaked out and taking these jagged breaths if I use a rebreathing bag and remove it and they quietly take several deep breaths. So we did utilize this. And I think it's on the packing list now is to have some small trash can sized 7 to 10 liter sized bags for rebreathing, and 101 other uses as things tend to go in that setting. So all of this, the observation, the history taking, the physical exam, the whole time, my whole goal is to figure out, is the origin of this respiratory problem is it coming from the upper or lower airway? And do I think it's infectious or non-infectious? So all the things we talk about, it's this simple. This is all I'm trying to figure out. Maybe this is oversimplifying, but this is what works for me. So as part of the exam, certainly in my practice, I use an exercise exam pretty frequently. And we did a couple here too. It looked a little bit different, as you might imagine. But we'd have the owner maybe just jog the horse out several paces and jog them back. And in that, I'm looking for noise. I want to determine if it's inspiratory or expiratory. Does the horse cough? What's the recovery like? Does the horse have increased effort at doing that jog? And this is a little tip. The students were certainly pretty excited to think about this one. And I think it's pretty handy to use. It's not perfect, but most of the time an inspiratory noise comes from an extrathoracic location. So if we think about that, a horse making an inspiratory noise, let's take strangles, for example, right? The retropharyngeal lymph nodes are gigantic and they're squeezing on the proximal airway. That is extrathoracic, and it does make an inspiratory noise. An expiratory noise is usually from an intrathoracic location. There is an exception to that, which I'm going to show you, but I want to play this video. So volume up if you don't have. I hope you just heard that grunt. So that's what I wanted you to hear. And I also wanted you to see, I hope everybody could appreciate the expiratory effort in this case. It's by no means the most dramatic asthma case. We actually don't see a lot of dramatic asthma in California. And we certainly didn't video horses very often on this trip. So I threw in this example. The expiratory effort is the point here. Expiration is a passive event. It actually requires no muscle engagement. And so when you see that abdominal push, just behind the rib cage, you see that abdominal push, that's actually no longer a passive event. That's an active expiration. And that is very prominent in asthma cases. So I was saying with the expiratory noise, which this horse made, being an intrathoracic cause, the exception, at least one really good exception, is dorsal displacement of the soft palate. And so if you can remember that, I'm not going to show you that video again. I'm going to show you this one. If you can just remember that one exception, that rule holds pretty true. And so I was going to show you just this. This one is pretty quiet, but does have a little expiratory noise. You may not be able to hear so well, particularly when the horse goes away from the camera. Great. Since a picture is worth 1,000 words and a video is worth 1,000,000, I wanted to just show you this. So there it is, dorsally displaced. It actually has a little ulcer, the tip of the soft palate. So that soft palate is billowing. Every time the horse exhales, air just rushes under it and it billows upward and makes a noise. Some dorsal displacements are silent. Some people describe as sort of a growl. There are different ways of describing it, but I wanted you to have that visual and picture that soft palate billowing every time the exhale puts air under it. And that's why that's the exception to the rule. That's why the noise is expiratory in that case. That was an aside. Okay. So at this point in my exam, again, we've done history, observation, physical exam, usually some sort of exercising exam, again, with the horse either lunged or trotted. This is when I have decided which imaging diagnostic I want to use. And again, I'm looking at, do I want to image the upper airway or the lower airway? And many times you can figure it out through the process, not every single time. So sometimes you have to look at both upper and lower. And so for upper airway, we do a lot of resting or standing endoscopy. We do a fair bit of dynamic endoscopy. Obviously, neither of those are available in the working Equid setting. For lower airway imaging, radiography, I actually probably lean towards ultrasound first. That's obvious. That's just easier and quicker to do than radiograph the adult horse lungs. So of these diagnostic modalities, ultrasound is the one that we had available to us. And this is not a machine that I've used before. Maybe many of you have used it. I was very pleasantly surprised by how well it worked on the thorax, on lungs. And this was the perfect place for it. I really think the only limitation is a phone being charged. I mean, I really think that's about the only thing that we ran into is the phone that had the app on it being charged so that we could use it. But it really was very, very helpful. And this is one of the students learning how to ultrasound, holding the phone. And obviously I'm just standing over him watching. But the foot plate of this probe fits nicely between the ribs of the adult horse anyway. And the image quality for what we were doing, again, ultrasounding thorax primarily, was really fantastic. So I was thrilled to have this tool, and I'm assuming that it's available on some of the locations and not all. Is that accurate? Yeah.
Yeah, That's accurate. More and more it is available.
Great, great. This was really useful, and it was great to be able to teach the students how to use it as well. So these images were not taken with the butterfly. We did not have the capacity to, or probably the knowledge is the right word, to store and then upload the images that we took with the butterfly. I'm sure with a little bit of time reading the manual, we could do that. But I wanted to just show these images, the sort of basic things that we're looking for. The top image, number 1, is an image of a horse with pneumonia. You can appreciate consolidation in the dark bit there with some variably echogenic bits within that consolidated part. The second image is from an asthma case. And asthma can look like different things. It can look totally normal. Severe and certainly chronic asthma does change the surface of the lung, and you'll see many comment tails. And then the third image is one with pleural fluid, just to show that, and a bit of lung, consolidated lung, sort of floating within that fluid. The fluid actually looks fairly cellular in that it's not black, it's sort of speckly gray. And the triangular piece is some floating lung that is non-aerated. So those are sort of the basic things that we were looking for as we scanned horses on this trip. So after imaging, I then am looking at laboratory diagnostics, and I've listed here the things that I would normally consider, and probably many of you would as well. And the ones that don't have a line through it are what we had available. The one, right? What we learned, we actually took some samples on this trip of different things, and they were delivered to the local veterinary school, but they just don't have the funds to run these samples for us. And it really sort of brought home, I think, the point of you have to make a decision with what you have. You don't get to look at, you just don't get to look at a fibrinogen, right? You just don't get a trach wash or a BAL. So you have to rely so heavily on those initial steps, the history, observation, and physical exam. So serum amyloid A, we had a very small number of test kits. I think maybe we had 3 or 4 for the trip, something like that. And I'm sure that varies trip to trip, the availability. Hopefully that'll be available more. I do think it's super useful in this setting. You guys have probably all heard a million times, serum amyloid A is the primary acute phase protein in horses. And as such, in health, its value is pretty well zero or close to zero. We tend to say under 50, but close to zero. There have been a number of great papers, since the advent of the handheld SAA reader, and we wanted to understand more about it, of looking at various disease processes and SAA. And there've been a handful looking at respiratory disease and SAA. And I've put a graph from one of them here that's looking at SAA and monitoring clinical response to basically antibiotics in horses with bacterial pneumonia. And the takeaway from this is of the various lab values monitored, fibrinogen, total white count, neutrophil count, and temperature, SAA was the only one of these that actually did correlate well with resolution of disease. And I think it also, I like SAA a lot for helping me decide on these respiratory cases, is this infectious or is this non-infectious? In asthma cases, and there are a couple of great papers looking at this as well. In asthma cases, SAA should be 0 to low, right? It's not an infectious process. In either viral or bacterial or even fungal pneumonia, SAA will most often be very elevated. The limitations of this test are it is an acute phase protein. And so the half-life is quite short. And so depending on where you, the veterinarian, are entering in on this disease process, you might be on the rise of that SAA. You might be on the decline of that SAA. And so I think recognizing that is important. I find the biggest value in the SAA test to be being able to do serial tests and look at the trend. Are we increasing? Then we're not going the right direction. Are we decreasing? Seems like we're going the right direction. So I use it that way as a trend, and I also use it to help me decide just right then and there. Elise will often pull out the SAA and we'll get one running sort of while we're doing something else, just to help figure out, is this an infectious respiratory disease or is this a non-infectious respiratory disease? It's not, you know, the infectious cases are not always febrile. Non-infectious cases could be hyperthermic, and certainly in the setting of high ambient temperature and humidity, they are. So I think knowing the limitations of the serum amyloid A test, I find it to be a super useful test. Again, there were very few on this trip, which really meant we had to think really hard about, was this the right case to use it on? And I think that's a good exercise, right? To have to really, it gets almost easy to be able to like, we'll run an SAA and a CBC and a fibrinogen. And I thought it was actually really good to really have to think about, this is day 2 and we only have 2 SAA kits left. Is this one that we want to use it on? And it was a great exercise for the students as well to really have to think about that. So this is when it would be nice to be able to see all your gorgeous faces and see a show of hands. How many of you have seen this mnemonic device, the DAMIT? I think it's limited to veterinary medicine, but somebody can tell me if they use this in human medicine as well. It's when you're really like, I have no idea what's going on here. This is what you refer to. You don't just say, damn it. You refer to this mnemonic device to help you sort of run through the potential causes of disease. So I have them all listed. I'm not going to read them off to you, but it was something that I wrote down and talked with some of the students about. Like, if you are just like, I have no idea, then just start going, do I think it's a degenerative disease? Do I think it's developmental? And sort of work through and narrow down the potential causes. Here's my simple, literally, we're back to this, right? Really, with respiratory disease, is it upper or lower airway in origin? Is it infectious or non-infectious? That's going to lead me in the right direction if I can figure out those 2 things. This is fantastic and just more nuanced, but this is what I'm trying to figure out, certainly at the higher level in my practice. And this is what I was trying to figure out in Costa Rica with the working horses, because it matters how we're going to address them, how we're going to manage them, knowing the difference in these. So an example case is this horse presented for vaccines, as many of them did, right? They came for the vaccines, they came for dentals, hoof trims. On history, yes, the horse had lost a little weight recently. She doesn't look too thin here. May or may not be pregnant, which in some of the regions was a pretty common answer. And had a rectal temperature of 102.6 Fahrenheit. You can see the heart rate and respiratory rate were also a little elevated. And on auscultation, increased bronchovesicular sound. So that's a big word that really just means you can kind of hear more than you would expect to for the body condition of this horse. You just hear more sound than you normally would. So what do you do with this horse? It's there for vaccines. Do you run a serum amyloid A to see if that, if your physical exam findings are because it's an infection, you only have 2 left or maybe 1 left on this day? Do you pull out the ultrasound? there are 152 horses waiting for you. I learned to get over that. I'm somebody who likes to stay on schedule. I hate to keep people waiting. I had to get over that. It was free, so that helped that they were getting the service for free, that they could wait a little bit. What else should we consider? We did ultrasound, as you can see there, because it was a great opportunity to do so. That's actually a different horse, but what we decided on a number of these cases that presented similarly is as simple as stand them in the shade and see what happens. And an hour later, this horse's values were quite a bit better just from standing in the shade. We did ultrasound and the horse had no abnormal findings. So we were comfortable proceeding with vaccines at that point. The primary diagnoses in working equids, asthma was the primary thing that I saw in the Osa Peninsula. I did ask some colleagues what other sorts of respiratory diseases they have seen, because again, I've done just the one trip and I recognize that that's a pretty limited view. Certainly pneumonia. Parasites are at least suspected as the cause of pneumonia in some cases. There are a lot of donkeys. And so, of course, they can have dictyocollis as a primary, or in the younger horses, migrating ascarids can certainly set up respiratory disease. And I'm sure most of us have seen that in our own practices. And that would be no different in most of the places that EI would service. I heard from some colleagues that fungal rhinitis is suspected, or sinusitis is strongly suspected in cases. Conidiabolus, I think, is the one. We did not see any that we suspected, but nasal discharge, percussion of the sinuses, and sometimes distortion actually of the bones overlying the sinuses would certainly clue one in to pretty massive growth in that region. And then Dr. Gray mentioned altitude sickness that he has suspected in Peru, though I've not seen that. So maybe some of you can comment on that at the end. So management, I'm hoping that I wasn't sold as somebody who was going to teach you how to manage these cases, because I struggled with this a lot. How do we manage these cases that are in front of us for, an hour at most, only because we made them wait in the shade before we have to give their vaccines. But in other cases that were primary respiratory cases, and we're never going to see them again, that was probably the trickiest part for me, really trying to think about what can we do. And what it really came down to is what we can't provide in resources, we tried to provide in education. So a horse who presented with asthma, with increased respiratory rate and that abdominal increased expiratory effort, then we would try to talk to them about not working in the heat of the day. Maybe this horse is better first thing in the morning, or is better in certain months of the year to use. There were a couple of horses that we did give sort of rescue drugs to for asthma. And that would be buscopan, certainly a safer way to bronchodilate than atropine, and dexamethasone, but knowing that's super short-lived, right? Like that helps today, that helps with their walk back home, but that's not helping their asthma. We're not able to nebulize bronchodilators and mast cell stabilizers and corticosteroids to these horses. So, and everything is wet. And so I'd be curious to hear from some of you as well, if you think some of the management things that we use, that we recommend for asthma management in the US are even appropriate. I mean, everything was wet there, like including your socks all day. And so, I don't know. I didn't do things like recommend wetting the hay. I also thought they would laugh at me, but I'd like to hear from others on that. We did recommend antibiotics for a couple of cases, and that would obviously in the working equids. I certainly didn't see anything or hear any histories that made me suspicious of a viral infection. Hear that it had spread through the group. I'm sure it occurs, but that's not what we saw. And so antibiotics, I think we had trimethoprim sulfa, and so that's what we would use and send home. I don't know if antifungals are part of the kit that would be available on any of these trips, but that would be, I have to say, that would be pretty tricky for a fungal rhinitis or sinusitis, because as you know, different fungi are susceptible to different antifungals, and a lot of antifungals are super expensive. So that may be pretty unrealistic. And then you may be wondering why on earth I have screwworm on here, but if you were on this trip, you would know exactly why I have screwworm on here. And I'm hoping I can show you. Yes. So this girl just presented, I mean, she really came for vaccines. She was extremely dull, nearly obtunded. As you can see, very poor body condition. Very abnormal lung sounds. This is actually before we had the butterfly in our available stock. So unfortunately, we were not able to ultrasound her. Imagine the internist looking at this super sick horse, clearly multimodal disease going on, and I got nothing. I don't have an ultrasound. I don't have anything. Anyway, this horse with the super abnormal, she did have a little cough. She had very abnormal lung sounds. I wonder if this will, no, I couldn't get this one to play. So it's a still, if you're squeamish, you wouldn't have wanted to see the video anyway. It turns out she had myiasis. She had screwworm infestation, certainly in this ear. And so of course I went, and as soon as I could get cell service, I'm reading about screwworm. Like, you only learn about that in vet school. I'd never seen a case of screwworm. And some cases can have systemic signs. They are ill enough from the infestation that they develop multimodal disease, as this one did. So we did put this horse on trimethoprim sulfa. And I told you I was worried about compliance, right? I just didn't know. Would they believe how essential this is? This is one of, I think, maybe 2 cases we were able to recheck on this trip. This is the ear when we found it, after 3 days after we'd seen the horse and left the gentleman with instructions, the owner with instructions to clean the ear, give the antibiotics twice a day. This is what the ear looked like when we arrived. He had been cleaning that ear. Elise had actually brought fly masks to donate. And so we gave her a fly mask, but as you can tell, it was way too big for her little tiny Costa Rican head size. And so the owner ran to his little house and got some thread and sewed this, sewed the nose of the mask, and he found a sock, and he sewed the sock onto the fly mask so that flies couldn't get back in this exposed ear. I was not worried about compliance anymore after seeing this case. And this was the most impressive thing that I saw, was the dedication to this, this just sad looking old horse. And he did a fantastic job on this horse. This is the group that I was lucky enough to spend time with in Costa Rica, with one of the farm owners standing on the side. It was an incredible experience. One I'll never forget. We have a little WhatsApp group, and we periodically, somebody will post and say hello and chat, which is really fantastic. I'd like to thank all of you for being here and having an interest in EI, and be happy to take any questions and or hear just input on any of the things that I shared, or different experiences or thoughts.
Thank you, Phoebe. Dr. Smith.
Yeah, thank you,
Yes.
Dr. Smith. I'd like to take a moment. Oh, sorry, Angie.
No, please go. I see your comments here.
No, that's okay. I was just going to follow up with what Dr. Smith said, that we in this program learned about screwworms as well, kind of in real time with Phoebe, and it was a reportable disease. So we were able to send this information along to the governing agency there in Costa Rica to add to their national statistics. So it was certainly quite the case for this team, for this team to be seen and be a part of, because it's a kind of emerging challenge in Costa Rica. And I was also going to follow that up with, we're quite honored here tonight to have EI's co-founder, Dr. Jay Merriam, join us. And he has seen a myriad of these issues through his, I don't know, Jay, 30 plus years of doing equitarian work. So I didn't know if you had any comments, Jay, to follow up with some of the cases that you've seen, to put you right on the spot.
Just, I have to admit, first, War Eagle, Dr. Smith.
War Eagle.
All right. I have to say, we have seen screwworms in other parts of the body, including the genitals, but never in the ear. And I congratulate you on digging into this and really seeing what's going on. The other thing, again, I think you'll agree that taking veterinarians out of their comfort zone, as we do in all of these workshops, ends up making you a better diagnostician. You depend on being a physical diagnosis person rather than all the toys that we have at our disposal. So congratulations on a wonderful presentation. And I know that we're going to see you again in one of these venues. I'm sure of it, right? Right.
Thank you. And very well said about it does make you a better diagnostician. And it reminds you, if you're a seasoned veterinarian, that you do have those skills. And it teaches you, if you're a young veterinarian, to have and to rely on those skills.
I have to say, when I was at Auburn, long ago, there was a Dr. Gibbons there who was world famous and taught a course in physical diagnosis, which I, as a smart aleck graduate student, thought, oh, I'll never learn anything here. I want my X-ray machines. I followed that man around for a year, and physical diagnosis was what he did. Wonderful, wonderful. And yes, starting students off with good physical diagnosis skills is critical. So again, congratulations and thank you.
Thank you.
Yes, I have to say she rose to the challenge of creating a stepwise approach in areas where you're often tempted to just think you're seeing zebras all the time, because you're seeing a lot of donkeys and a lot of mules. And so thank you for that. There is a comment from one of the, from Dr. Cortez, that I'll read to you here, Dr. Smith. In Mexico, we use a medicine called universal drink. It contains guaiacol, chlorpherenamine, and chloroform. What do you think about its use? Excellent talk. Very grateful to Equitarian. And I don't know if you'd like Dr. Cortez to comment a little bit more about any of those ingredients first.
I probably can't comment on it. I assume it's a sedative, or maybe we can see what it's used for. Is it like a cough suppressant or sedative?
I don't know if you're able to unmute yourself or comment back. Wendy, thanks for your comment.
See if I can find the chat.
Hello, everybody.
Hi.
Hello.
And I'm a baseball play game. In this moment, excuse me, but the noise. My English is not very good. I try talk about the question. In Mexico, use too much to the respiratory disease, this medicine. Generally, when the horse present cough,
Yes.
and the flu, use the medicine. The question is, you use chloroform or chlorpheniramine in the treatment?
I have not. There are other medications that are used to suppress the cough, right? It looks like most of these ingredients would be for cough suppression. You know, I guess I am more focused on the origin of the cough and treating that, the cause of the cough. I don't very often treat the cough itself, if that makes sense. It seems that horses...
¿Necesita que traduzco? Sí, puedo, si quiere.
Ok. Gracias. Más cómoda me siento.
Okay, is that all right with you, Dr. Smith? Before I forget what you said. Se dice que prefiere tratar o curar a la razón que hay que hay tos, más que tratar al tos directamente. Entonces, no comúnmente no utiliza muchos medicamentos para el tos. Please continue.
I think that's it. Thank you for that.
Sí, básicamente es lo que generalmente usamos aquí en México y desgraciadamente lo usan indiscriminadamente para cualquier situación de afección respiratorias en los caballos. Pero qué bueno que estamos en su plática para aprender mucho más acerca de estas enfermedades respiratorias que afectan a los caballos. Me siento muy agradecida de poder estar presente y poder aprender de ustedes. Muchas gracias.
No, a ti. Gracias por la pregunta. It's very indiscriminately used, she says, for a host of almost whichever respiratory disease is presented, and she thanks you for giving this talk to increase knowledge.
My pleasure.
I promised a survey and then I neglected to post that. If you would be so kind as to check the link and click on the link before you log out of tonight's meeting. It's coming your way. We would love to know what you thought of tonight, and if you have any other questions or comments for myself, the rest of the Equitarian team, or any comments about Dr. Smith as feedback. I would
Any
also...
any comments about me? Wait a minute.
About the shirt, no. I should say, if you have any feedback about tonight's session. And
Perfect.
our next webinar, I'll just give a plug for bi-monthly, so every other month will be the third Wednesday of October. That puts us at October 16th. If you want to mark your calendars, it will be at the same time of day. Topic to be determined. And again, Dr. Smith, just a hearty thank you for this. We really appreciate it.
Yeah, thank you to all of you guys, and thanks to everyone who joined us tonight. Especially big thanks to Dr. Phoebe Smith, who continues to donate her time and share knowledge with the Equitarian community. So we're so lucky to have folks like you in our corner. For those of you who are attending tonight, you're likely here because you're already a member of this growing movement to support the world's working equids and all those families who rely on them. And if you feel moved by what you've learned, or if you just started learning within the context of EI and the horses, mules, and donkeys that we serve, we absolutely encourage you to get involved. Efforts like volunteering and spreading awareness about this global challenge are just hugely impactful. But we also need our team at home to make this work a reality. You know, personally, one of my most preferred methods of giving to any organization is being a monthly donor. As just a rogue example, as a member of the Equitarian home team, I know that my contribution is working all year long. In the automatic payments are super easy to manage without having to remember anything on my to-do list, because, you know, this is so important to me, and I know it is to you guys too. Really, any amount, big or small, it just makes a huge difference in our ability to provide this education, healthcare for the world's working animals who really truly need it most, as you've seen from a lot of the photos you guys saw tonight and a lot of the images. So if you're looking for a way to get involved, that's a great way to do it. Visit our donation page at equitarianinitiative.org, select the recurring donation, choose your giving level. And really, like, you guys are the reason we can do this work. So please don't underestimate your impact as an individual. You guys make this community robust in this passionate sector of the veterinary and animal healthcare industry what it is. So we're so grateful for your support. So as Angie said, if you guys have any other questions about EI and our programs, visit our website or contact Dr. Angie Barnum or myself directly. We'll post those in our email addresses in the chat. So again, thank you, Dr. Smith and the Equitarian team for bringing this very engaging and informative webinar tonight. Appreciate all of you.
Bye, everyone.
Good night.